A very good morning to one and all present here. I'm Dr. Sayachna, Associate Professor from Chettinad Dental College and Research Institute. Today, I'm going to discuss a topic about surgical management of obstructive sleep apnea, an overview from a dental perspective. At the end of this lecture, you will be able to know what is OSA and its dental manifestations, how to screen and refer for surgery, what are the types of surgery, its indications, and the benefits of surgery. For time constraint, we are not going into the detail of how the surgery is being done, but its outcome and the surgical management of OSA is being discussed here. Now, why do we need dentistry in OSA? It's because mouth is the mirror of the body, as all the conditions that affects the systemic health also affects the oral health. Now, apnea means without breath. Hence, this obstructive sleep apnea is a potentially fatal condition and it should be screened and identified as early as possible. The management of OSA follows a multidisciplinary approach. The role of dental professionals, especially the oral medicine and radiologists, starts first because they are the first persons to screen and identify the presence of OSA. They refer them to orthodontists if they identify a skeletal or a dental pathology contributing to OSA. These orthodontist specialists are the ones who also give mandibular advancement devices which are useful in the treatment of OSA. If the OSA presents in a children, it is referred to pedodontics. And our hero of the presentation today is the oral and maxillofacial surgeons. They rectify the surgically modifiable anatomical tissue and improve the prognosis in OSA. Classification of sleep apnea disorders are of three types: the central, obstructive, and the mixed. And a quick recap on the AHI scores, that is apnea, hypapnea scores. They are categorized into mild, moderate, and severe based on the apneic and hypopneic events per hour. Mild is 5 to 15 events per hour, whereas moderate is 15 to 30 events per hour, and the severe is more than 30 events per hour. A quick glance on the etiopathogenesis. Now, in this section, you will be able to see the airway slice, right? Now, when you don't have any obstruction, the air enters through the nasal cavity, the oral cavity, the pharyngeal cavity, goes into the trachea and reaches the lungs. Imagine if you have any complications like a sinusitis or an elongation of the uvula, enlargement of tonsils or any growth, benign or malignant, then the free flow of air will not happen. This is a normal patient. In sleeping position, the air, that is the blue line, the air goes in freely without any obstruction. But in cases of OSA, the tongue may fall back and obstruct the air passage. Hence, can you see the blue line going until here, but it is getting obstructed. Only a thin line of air is going inside. But if the obstruction is severe, then there will be complete absence of air going inside, causing OSA. Okay, so this is because of the inadequate motor tone of the tongue or the airway dilator muscles. That is why your airway collapses. And this repeated oxygenation and deoxygenation causes oxygen desaturation and sleep fragmentation. So, as you can see here, air is going in and coming out without any problem and the patient is standing. But in sleeping positions and in supine position, the obstruction happens and it may be due to a single cause or multiple causes. Single cause may be just a tongue falling back, but in cases of macroglossia accompanying it or a polyps accompanying it or a DNS or relaxation of pharyngeal muscles, the severity of OSA increases and thereby it will lead to snoring and obstructive sleep apnea. So now OSA and dentistry. There are certain risk factors which could cause an OSA. In dentistry, it could be due to hard tissues or it can be due to soft tissues. When hard tissues, it may be due to a micrognathia, that is small jaw. Sometimes the maxilla also can be small due to the presence of syndromes. Okay, so these jaw discrepancies can lead to malocclusions. Okay, can you see the maxilla is inside, mandible is outside. Whereas it can also be due to soft tissue pathologies where there is a macroglossia here, enlarged tonsils, it may be an elongation of the uvula, and also inadequate muscular tone. And this one is mostly looked by the anesthetist because they'll be evaluating the airway, right? So Mallampatti score 3 and 4 are more prone to OSA. Now we move on to the oral manifestations and OSA. Because the patient often opens his mouth, it causes dryness of the mouth, so leading to xerostomia. And because of the aortic discrepancies, we have a malocclusion occurring due to it, right? So this decreases upper oropharyngeal airway. And periodontitis, that is the gum and the periodontal infections, increase because there is a pre-existing inflammatory response already in OSA, and this gets triggered to it, right? Okay, it worsens the periodontal inflammation and hastens the bone loss. This bruxism is seen mostly in moderate to severe cases of OSA. This is actually a protective reflex to continue breathing. It's acting as a temporary mechanism for the oropharyngeal airway to open. Okay, so as you can see, there is irregular teeth surface that is due to the clenching of the teeth and the jaw. This serves to restore the muscular tone in the upper airway and reopen the airway. Okay, and there is taste change. This is because the constant oxygenation and reoxygenation. This taste change is being appreciated by certain patients. And TMJ disorders, because of constant clenching of the teeth, the muscles get fatigued and also goes for a spasm. So, early identification of OSA is very much appreciated for the treatment of OSA and to reduce its morbidity of OSA. So, because of this potentially fatal condition, this OSA must be screened and identified at the earliest. When a patient gives excessive daytime sleepiness, inability to concentrate, restlessness, irritability, and disruptive snoring given by the partner, a physical examination should be done to evaluate whether the patient is obese, has enlarged tonsils, high arched palates, retrognathia, okay, or micrognathia. The patient's comorbid conditions also have to be taken into consideration on treating OSA. That is like cardiac diseases, uncontrolled diabetes mellitus, hypertension, all some metabolic disorders should be taken into consideration and it has to be treated. They have to be subjected to a screening questionnaire, and moderate to high risk OSA are usually looked for. Within the mild cases, lifestyle changes like dieting, refraining yourself from alcohol and smoking is recommended. But whereas for moderate OSA sufferers, mandibular advancement devices are being recommended. These are usually done by the orthodontist. As the name says, it advances the mandible and helps the tongue to be placed forward, not obstructing the airway. This is the CPAP treatment. This CPAP treatment acts as a pneumatic stent, preventing the airway from collapsing. Moderate to severe cases are usually referred to surgery. Now, what is the goal of treating OSA in surgery? It's to improve or eliminate the airway collapse. It also preserves the normal function, right? You can't just cut it and throw everything out. So you have to preserve the normal structure. And also you have to improve the quality of life and psychomotor vigilance of the sufferers, so as to eliminate snoring and the sleep apnea. We know the goal. Now we have to know the indications for surgery. Not all patients need surgery, right? So the indications for surgery is mostly failure of non-surgical treatments. As I said before, CPAP therapy, oral appliances, or the lifestyle adjustments. And when the AHI score is more than 15 to 30. When the patients do not take CPAP therapy, okay, or its tolerance is very low. And when you have a surgically correctable anatomical issue or multiple sites of obstruction. So, these are the pre-op considerations in surgery for OSA. After you have a thorough history, the severity of the OSA must be often evaluated through polysomnography, which is the gold standard, and determine the extent of airway obstruction and choose the best choice of surgery. After evaluating this, we will be subjecting the patients to blood test evaluating the coexisting health conditions. Now, why is this important? is because it reduces the complications and improves the surgical outcomes, especially in the cases of diabetes mellitus, right? So there will be poor wound healing, or in cases of hypertension, it may be excessive bleeding. So comorbidity also must be evaluated and brought to control before proceeding for OSA surgeries. Okay. And a very important one is the informed consent. An informed consent gives the patient an idea about the rational risks and the expected outcomes of the surgery. Okay. So after these 3 preliminary steps are done, we will go for pre-operative evaluation and planning. Okay. Our objective is to assess the patient's anatomy. What is wrong and where exactly it is wrong, and what is the degree of severity of OSA. And then we subject them to imaging. Imaging can be for 2D and 3D. You have to select whichever suits the need of the patient. Then you subject them to a sleep study and a soft tissue analysis. This is very important in the outcome of a surgery. So you should assess the soft tissue dimensions to anticipate the effect of facial aesthetics and airway patency. Now, investigations. The 2D imaging, like a lateral cephalogram, will be proving very useful as it clearly shows the airway. Well placed here for evaluating before and after surgery. MRI and CT scans can be subjected to identify the pathology's presence. In cases of MRI, here you can appreciate the soft tissues better. This is the clean view of a airway, and this is the tongue. The soft tissues can be well appreciated in this. Whereas in CT, bony pathologies are mostly seen, but in soft tissue window, an adenoid enlargement can also be identified. Now, the cool stuff, that is the 3D imaging. This is the latest technology which helps you to assess not only linear dimension measurements, but also superimposition of pre-op and post-op CBCT. See, in this picture, can you see the red color is the pre-op and the white color, this is the post-op. Okay, so we can really compare and give a contrast to the patient as well as to assess for ourselves. 3D CBCT measuring airway space. Now, this gives a airways measurement in various spaces of in a patient. This can be used to evaluate the airway space before and after surgery. Drug-induced sleep endoscopy. We will not put the patient to sleep, but a sleep-like condition. This is usually done by an ENT specialist. Okay, drugs like midazolam, propofol, ketamine, they are used alone or in combinations with them to achieve a sleep-like conditions. Why do we do that? Is we can evaluate where exactly the obstruction happens. Okay, so like here there is a lateral wall collapse, here there is a retrolingual collapse. So we can view the collapse when and there when it occurs. Okay. So now this can also give us a clue on to differentiate between the central and the obstructive types. So now we have assessed what to do before surgery, right? So identify the high risk patients and alert all the care team members, including the staff and the pharmacy personnel. The support staff may not give you an adequate response from their side. So everybody should be informed about the patient condition for a smoother transition during and after surgery. And after the desired surgery is done, you have to extubate the patient. This is done by a well-experienced anesthetist and a good team which comes around with it. The extubation protocols has to be done by the anesthetist. They will extubate only when the patient is fully awake, and the patient's position is very much important, because if he is not put under the semi-upright position, then there is chances of the tongue again falling back and worsening the OSA. Okay, so recovery position is also in the lateral decubitus position. This must be followed for a smoother transition of the patient after anesthesia. Okay, there should not be any pain sedation mismatch, and for a sedation management, a Richmond scale 0 is recommended. And after the patient is out of the surgery, he should be monitored and intervene if necessary. Monitored meaning you should always look for any desaturation. Okay, what tools that will help for desaturation are the presence of capnography or the pulse oximeter. These two will analyze the oxygen and the carbon dioxide level and help you prevent the patient from going to desaturation. And a CPAP can also be recommended if needed by the suffering patient. Okay, this can be transferred to the outpatient facility and again to the patient after surgery if needed by the patient. So now we have discussed what we have to do before and after the surgery. We'll go directly into the type of surgical procedures now. The soft tissue obstructions. The soft tissue obstructions are mostly the soft palate. So palatal surgeries to remove the tissues from soft palate, and the tongue, that is the macroglossia, right? So a procedure used to reduce the size of the enlarged tongue. Whereas the hard tissues like the maxilla and the mandible in cases of deficiency has to be advanced in front to bring about the extra volume so that it can accommodate the tongue and prevent it from falling back and causing OSA. Also, newer bone formations like the distraction osteogenesis will prove helpful. Then the genial tubercle advancement with or without hyoid myotomy can be planned. Then what is there without newer technologies, right? So, laser assisted surgery, TORS, that is robotic surgeries, radio frequency ablations, and hypoglossal nerve stimulation will be seen here. Now, the soft tissue resection. This uvulopalatopharyngoplasty. This is the most common surgery used to eliminate the causes, the soft tissue causes obstructing the airway. Since this is already done by Dr. Muthukumaran sir, I will not go in details of it. But this surgery does not mostly address the lateral pharyngeal wall collapse. That is why we recommend suspension palatoplasty. The suspension palatoplasty is a newer surgical technique used to treat OSA. Mostly correct the retropalatal obstruction in patients. It may be due to a small tonsil of grade 1 and 2 quality, and also the AP, that is the anterior posterior palatal obstruction. It is usually recommended to the moderate to severe cases of OSA and is done under general anesthesia. In this surgery, we don't cut the muscle, instead we advance it. Okay, we advance it and elevate it such a way that the levator palati muscle closes the nasopharynx during the swallowing and phonation process, so that we will prevent the cleft like lesion from occurring. And also, this will prevent the velopharyngeal insufficiency. Then you see, this is the intranasal view. This is the pre-op condition. And during surgery, the excessive obstructions are being removed. Then it's the nasal view here. You can see how much of space is now being gained and the airway is open after the surgery. And the post-op lateral cephalocleft. This is the pre-op, this is the post-op. So, on comparison in numbers, the AP diameter according to a study has been improved from a 23 mm to 184 mm. And also the lateral diameter has increased from 167 to 336. And the AHI is drastically reduced from 18.5 to 2.1. Surgery which can give 50% reduction in OSA score, that is AHI scores, is considered successful. Now, tongue is a very powerful organ. It's highly innervated. You have to preserve the arteries and vessels wherever possible. So, when considering the debulking of the tongue, the manipulation should be mostly restricted to the dorsal aspect wherever possible. Okay, because the ventral surface will be avoided to avoid injuries in the lingual arteries, nerves, and the hypoglossal nerves, right? So, care must be taken to preserve the ventral surface and keep it to the dorsal surface. Okay, the tip, the lateral borders, and the shape of the tongue yield better results. So, care should be given on pre-evaluation of surgery and resect accordingly to remove the obstruction. Now, the glossectomy can be done in two ways: the midline glossectomy as well as the lateral glossectomy. The visualization is a very important factor, right? So, in the midline glossectomy, a rigid fiber optic scope is used to visualize the surgical field. Then, the surgeon can excise the excess tissue using a scalpel or laser or a plasma pen. The surgeon excises both the midline and the lateral part of the tissues, and a tunnel is created in the railing. So, this debulking of tongue causes lesser fallback, and patient can try to accommodate the tongue inside the oral cavity. The mandible can hold it. Can you see now? The patient is not putting out the tongue here. So, the patient has a successful glossectomy done. Okay, which prevents the tongue from falling back, causing OSA. Lateral glossectomy, the amount of excess lateral tissue is usually marked here, and the sutures are placed and the glossectomy is done. Okay, tongue retraction and intermittent release should be done to reduce the tongue edema and ischemia. The outcomes of this surgery will be lesser anterior occlusal abnormalities, as you've seen here, right? So, this is the pre-op and this is the post-op. And since tongue reduction surgeries has very minimal morbidity and mortality, it's usually well accepted by the patient, and care should be taken to avoid bleeding. If there is excessive bleeding, identify the bleeder and cauterize or go with coablators. So now we have resected the soft tissues. We are going to see what are the hard tissues that needs to be resected for the treatment of OSA. This MMA, that is nothing but the maxillomandibular advancement, is the most recommended surgery with a higher success rate. Okay, so this advances the maxilla and the mandible forward, right, with the Lee-Ford 1 maxillary, the sagittal split mandibular osteotomy. Usually 10 mm can be achieved during this surgery, but it depends on the case. It's usually recommended for severe OSA patients and is done under GA. The indications of this surgery are multiple level of obstructions can be done in a single visit, and preservation of pharyngeal tissues and its functional integrity to increase the airway space. It is also recommended, or it's primarily recommended, that should I say, for the skeletal discrepancies. The treatment planning. After a meticulous planning using investigations, we will determine the extent of the skeletal discrepancy and how much advancement is needed for this patient. Osteotomy of the maxilla is done. That is the Lee-Ford 1 osteotomy. A horizontal cut is placed mostly above the teeth, and care should be taken not to involve the nerves and the arteries that go through. This careful separation must be done avoiding the nasal cavity, and a down fracture of the maxilla is done for a controlled movement. Then we'll go for the mandible. Okay, so here also osteotomy is done in both jaws. That is why it's called bilateral sagittal split osteotomy. When the mandible is cut in the sagittal sections, preserving the IAN, it has been forwarded to the recommended distance that we have thought of preoperatively. Okay, and after the maxilla and the mandible are advanced forwards, it needs to be stabilized with screws in rods. Later, the occlusal adjustment also have to be achieved along with the advancements. So, while we do this, there may be some complications. So, there may be an edema and a hypopharyngeal hematoma which occurs immediate post-op. Okay, so the position is very important. Okay, because this may also cause a increased risk for airway collapse, and a bleeding may be expected after 2 to 3 days. So, measures should be done to control them. Infection, based on the severity of infection, antibiotic either single or in combinations with 2 or 3 can be prescribed to control the infection. Excessive advancements may cause complications such as the inferior alveolar nerve injury, the temporomandibular joints dysfunction, because if it's brought in front too much, it will cause the fatigueness of the muscles and the joint, and also malocclusion. Due to the same, okay, sinus complications or oronasal fistula may occur if care is not taken during down fracturing of the maxilla. So distraction osteogenesis. Distraction osteogenesis is generating new bone by corticotomy or an osteotomy, and you distract. It's not the English meaning distract. Distract is you bring about new bone formation. Described by the Elizera, where there is a tension stress principle. You expand the bone, allowing the new bone to form in between the osteotomy that you have made both in the maxilla and the mandible. This usually takes a month or two to recover, and the newer bone will help you gain the deficient space that is required for the tongue to be placed. Okay. So this is recommended in severe stages of OSA. This mechanical stimulation will lead to biological responses. The nerve, the muscles and the soft tissue all have to regenerate at the same time. Now, indication where you have deficient maxilla or the midface hypoplasia, and they also tend to struggle with nasal obstruction and lack of intraoral volume. As you can see, the mid-palatal suture will be expanded. An expander is placed in the maxilla and a quarter turn is given daily. Okay, 0.25 mm. Okay. When maxillary expansion is done, it is called as the dome. That is distraction osteogenesis maxillary expansion. Here, after a 0.25 force is being given here daily, 8 to 10 mm of expansion is achieved, after which the tooth which are malaligned will be corrected orthodontically to achieve a better occlusion. Okay, and it can also be done for the mandible. Okay, here you can see distractors, both intraoral and extraoral distractors are available. They will be used by the surgeons depending on the need. Okay, this surgery should not be performed if you have an osteomyelitic lesions in the jaw, or when you have osteoradionecrosis or any pathologies which affects the bone metabolism. Okay, so here an osteotomy is done and a hematoma formation happens. Okay, these are the phases of distraction osteogenesis that occur during remodeling of bone and new bone formation. Okay, first is the latency period in which the hematoma can be seen here. Okay, which is later replaced by the granulation tissue. Then during this stage, here there is new bone formation, first in the peripheries, then to the center. Along with this, the soft tissues, the muscles, as well as the nerves regenerate. Okay, and the end of this stage, maturation of the ossification in the distraction chamber happens. This is in the late consolidation stage. Then lastly, you can see now the length of the jaw is improved and there is new bone formation, muscle formation and the nerve formation, which results in bone remodeling and continuity of the alveolar canal after completion of this distraction osteogenesis. Complications. Care should be taken so not to fracture the bone, give excessive pressure, right? And also prevent any nerve damage from occurring during expansion. Excessive bleeding and device related problems are also common, so care should be taken to avoid the same. Okay, device problems meaning mostly it may not be placed properly, or sometimes it gets infected if the patient is not taking care of the site after surgery. Typical advancements of 10 to 30 mm for the mandible and 16 mm for the alveolus are possible from this surgery. Next is a genial tubercle advancement. The genial tubercle advancement is usually recommended for mild to moderate OSA patients for removing airway obstruction by anteriorly repositioning the jaw, because the tongue plays a major role here, right? So you have to reposition the tongue anteriorly. How we'll do is again by the osteotomy process. Okay, you have to reposition the anterior-inferior segment of the mandible forward. Okay, we are positioning it like this with the attached genioglossus muscle. So it is like a shelf. You pull it here without harming the inferior border of the mandible. Can you see here? The genial muscles are being pulled in front and it is being stabilized here with the plate and screw, right? So the outer cortical and the cancellous bone is either given in the shape of a rectangle or in some cases trapezoid. It's It's mostly dependent on the surgeon's choice. And the inner cortex is rigidly fixed with bone screws. This procedure not only helps in positioning the tongue more anteriorly, but also it increases the retrolingual space. Okay. The limitations are sometimes if you're not treating the hyoid position, there may be a delayed detachment. Sometimes the muscle can come out and it may need for resurgery. Genial advancements with hyoid myotomy and suspension. Now this osteotomy is done in the inner cortex of the bone. So this is done in the inner cortex of the bone where the genioglossus muscles is attached. Now the body and the greater corner of the hyoid are isolated. Care should be taken that you should not injure the laryngeal nerves beside it. Okay. So that the strips of fascia or non-resorbable suture are passed around the hyoid and the intact portion of the anterior mandible to complete the hyoid suspension. The suspension can be seen well here, right? While doing so, you are not only placing the hyoid in front, okay, you are anteriorly repositioning it, but also superiorly, okay. So this will prevent the hyoid muscle detachment, okay. And this will increase the retrolingual and the hypopharyngeal airway spaces in patients suffering with obstructive sleep apnea. Okay, this will also help the tongue to be stabilized. It's basically you're strengthening the anterior cavity, not only the bone along with the muscles. For RFA means radio frequency ablation. This is a minimally invasive surgery. It is usually done in the walk-in itself. What this does is it shrinks and tightens the base of tongue. Okay, so it can be done under local anesthesia instead of general anesthesia. This is recommended for mild to moderate OSA patients, okay, and it can be serving as a good alternative to CPAP. This radio frequency reduction of base of tongue, this is the procedure that will happen. A needle-like electrode will deliver heat to the submucosal tissue. This causes scarring and fibrosis and the tongue will shrink, okay, so leading to lesser collapse of the tongue during sleep, and thereby it is also making the tongue firmer. So the post-op care instructions is initially there may be a swelling which can cause dysphagia because of the tongue, but I've asked the patient to avoid vigorous rinsing or spitting for 48 hours. Infection can be well controlled with the help of antibiotics and an oral rinse. Pain management, depending on the pain that has been experienced by the patient, acetaminophen and narcotics can be given. Central depressant is not advised as it may depress the respiration. NSAIDs can be avoided too because it increases the bleeding. A soft, cool diet can be advised for 24 to 48 hours for the patient. And position again. Post surgery, the position of the patient must be done in a semi-upright position so that the edema comes down. How cool is robots, right? So TORS, transoral robotic surgeries. This is recommended for moderate to severe OSA. It is usually done under anesthesia. When do we recommend this transoral robotic surgery? Is when the patient does not cooperate for CPAP, okay, and when there is lingual tonsil hypertrophy. Transoral robotic surgeries. This is used for precision removal of tissue that is obstructing the airway. Can you see the robotic arms here? This is being done by a well-experienced maxillofacial surgeon. It also reduces the complications like bleeding and scarring. Then there is laser. The laser can be used for the uvulopalatopharyngoplasty, which we have discussed earlier, and to help reduce scarring and bleeding. Hypoglossal nerve stimulation or the HSN. This is the newer surgery which has been recommended to obstructive sleep apnea patients. This is recommended to moderate to severe OSA patients and intolerance to CPAP. This is done in general anesthesia. And under. There is 3 components in this surgery. Okay, one is the sensor lead, then one other one is the pacemaker, and one is the stimulation lead. This is the stimulation, this is the pacemaker, and this is the sensor lead. Now, the stimulation lead is placed near the hypoglossal nerve along with this branches. A cuff electrode, can you see it's been placed? This receives the impulses from the pacemaker, and the sensor lead is kept in the junction between the external and the internal intercostal muscles. Whenever this senses any hypoapnea or apnea during breathing, this sends an impulses to the pacemaker, which in turn gives an impulse to the stimulation lead. This hypoglossal nerve makes the genioglossus muscle to contract and bring the tongue forward, thereby so resulting in opening of the airway in the retroglossal region. Okay. So by doing so, you will have more space and reduced airway collapse. Okay. So outcome of the surgery based on STAR, that is stimulation therapy for apneic reduction, there is an improvement in sleepiness from 33% to 78%, and the quality of life was increased from 15% to a drastic 67%. And also the apneic AHI score has reduced 50%. So that is all a good indicator of a successful surgery. And later innovations of instead of these implants, a transcutaneous patches are also recommended in the submental area in order to stimulate the genioglossus muscle. Now complications, right? This involves a lot of components, hence complications has to be dealt with care. Okay, there may be technical issues. Technical issues is only after a month post-operatively will the machine be able to operate. Okay, so that time we have to check any malfunctioning in the device, that is it may not turn on or the leads may not be working properly. So you have to look out for technical issues, or the stimulation is too much for the patient. Hence a patient is given a remote control to adjust the impulses according to his need. Okay, care should be taken that the device should not be infected. Okay, if there is too much of infection, then removing the device may be considered. And the crucial step after surgery is follow up. Okay, so initial post-op should be done first few weeks, where the patient will be advised to go for a liquid diet and soft foods, and oral hygiene instructions are recommended for the patient to prevent infection. Okay, after 4 to 5 weeks, the patient is advised to remove the elastic and go for orthodontic, that is the clip therapy, to treat the malocclusion. CPAP therapy can be advised after. Both of them can be done together. Okay, and 3 months after the surgery, the patient should be recommended for a sleep study, which will help to evaluate the surgery success in treating oral SAP. Okay, and a final checkup can be done from 6 months to 2 years post-op, because in the form of x-rays or photos or exam to confirm healing and satisfactory results. So what are the considerations for resurgery? We have to consider other treatments, that is the non-surgical options like CPAP or a mandibular advancement device if an initial OSA surgery has failed. Okay, seeking for a more effective surgery like MMAs can actually prevent another surgery. Okay, with the weight gain. Sometimes the patient gain weight, which will cause obesity and compress the upper airway, leading to worsening of the OSA. If we don't plan correctly, there may be an unaddressed obstruction site, that is missed obstruction. If there is multi-level of obstruction, as I said, when 2 or 3 conditions coexist together and one is being missed, then you may have a resurgery done. That is why a multidisciplinary approach is always recommended. Then scar formations, especially in the cases of laser or multiple surgeries which is being done earlier, then it will worsen the airway obstruction over time and cause sleep apnea. And of course, age has to be considered. The natural aging process can cause a gradual increase in tissue collapsibility over time, which may contribute to the return of OSA. So we have come to the end of the session, and at key take-home messages are: dental surgeons play a key role in the multimodality team in the management of OSA. Screening and identification of dental risk factors and its oral manifestations will lead to early diagnosis of OSA, reducing its morbidity and the mortality. Interdisciplinary referral should be considered for giving an optimum management for the patient suffering from OSA. Skeletal and dental disorders causing malocclusions, whenever diagnosed, should be treated at the earliest, so especially in the growth phase, to address or prevent OSA complications. Apt patient selection, well experienced oral and maxillofacial surgeons, anesthetist, sleep specialist, and a good post op follow up will lead to a good surgical success. These are my references. Thank you for your patient listening. Thank you.